we have a great group of people this afternoon and some really fantastic talks. I'm really delighted to introduce our first speaker, Fernando Alarid-Escudero, who I had the absolute pleasure of serving on his PhD committee when he got his PhD in Minnesota. He's now moved on to bigger and better things in Mexico, where he's been modeling a lot of different infectious agents. Hope maybe he'll pick up coronavirus along the way. But he did some great work in his PhD on modeling H. pylori and gastric cancer, and so we're very excited about hearing us talk about modeling gastric cancer into the 21st century.
Hi, everyone. I would also like to thank for the invitation to be here and present my work. I also want to thank Julie for all the support and guidance that she provided me through my dissertation. And it's nice because I was able to meet her in person here at the summit, so another productive result or outcome out of this meeting. So the title of my talk, at least on the program, says Modeling Gastric Cancer into the 21st Century. However, I would like to do how I envision the 21st century modeling on 21st century with modeling gastric cancer, and for that is to do an actual cost-effectiveness analysis of screen and treat for HP in the setting of antibiotic resistance. And in this case, I did it in Mexico because of different reasons that I will talk to you guys about in a little bit. I would like to acknowledge my collaborators in University of Minnesota, here at Stanford and IMSS. And I also would like to thank Constanza because probably you guys already know that she's an enabler. And from a little bit of what I've seen her in action, she's like the glue of a lot of great things happening. And she was the one that put me in touch with Javier Torres. And so I'm really thankful for that, Constanza, so I appreciate it. And I'm also very happy and I feel proud that I'm sharing this panel with such great experts. I don't have any conflicts of interest to declare. So population screening programs. I will talk to you guys a little bit about screening programs and why do we use simulation, mathematical, or decision models. In this case, I'll use them interchangeably. So the idea of population screening programs is that we want to prevent and detect early the disease. In this case, for example, H. pylori or eventually gastric cancer. That's what we eventually want to detect early or prevent. What are the benefits of screening programs? Deaths from gastric cancer in this case. We want to decrease deaths from gastric cancer. That I would say the ultimate goal from a screening program. Then we have like some intermediate outcomes that are desirable. For example, morbidity due to gastric cancer or gastric disease. Also reduce the potential harms associated with diagnosis and treatment. We want to also reduce the treatment costs. And what we want to increment or increase our life years and quality adjusted life years. What are the questions that we can ask when we evaluate screening programs? Well, first, it could be, what is the evidence of the effectiveness of the detection? Now, that would be the most important if you have to be able to get data or conduct a certain study. This would be the primary question that we'd like to have an answer for. And as yesterday they were talking about, if you have more and more evidence, some of these evidences are supposedly to be conducted through these big clinical trials, or at least somewhat big clinical trials. The second question could be, okay, now that we know that screening provides a positive effectiveness, the second question would be, what is the optimal detection and surveillance strategy? And when I emphasize on the word optimal, I'll tell you guys in a little bit why. Then what are the favorable and adverse effects of detection in a population? Sometimes you would like to do it in certain subpopulation, but what if you would massively or implement it at a population level? What are the adverse effects of doing such or implementing such a policy? And then is the population screening cost effective when we want to outweigh the costs and the harms provided or induced by implementing such policies? Now, the first question most likely could be evaluated or answered using clinical trials or study designs with people where you recruit and apply them an intervention and follow them over time. But for the other three, it's tough to do it for clinical trials, because if I ask the question, what is the optimal detection and surveillance strategy? Technically, you will have to try and compare all feasible or possible strategies. And you start stratifying by at what age should I start, at what age should I end, what is the frequency at which I have to do the screening, with which, if there are multiple tests that you could use, then it would easily get out of hands, and eventually you'll see that you'll have more than hundreds of strategies that you could potentially want to compare among them. And with this, that's where we use decision models. So they are based on the best knowledge that we currently have on a certain disease, on some evidence. The idea is to extrapolate beyond that current knowledge and try to make some projections on how would the world look like based on that simulated world. So what is a decision model? So I decided to add a few slides on decision models for those of you that have not seen them before or have heard about them. So a decision model is often thought of as a black box. And a black box that like there are things that go inside, and suddenly like we use the output to make decisions. But what exactly goes inside the black box? Well, inside the black box is actually a mathematical model. Most decision models, if not all decision models, even a simple decision tree, for those of you that have had experience with simple decision models, which to me are the most powerful, because at the end decision trees are the ones that synthesize all the evidence from more complex mathematical models. So as any mathematical model, we have inputs, in this case reflected by the variable x, and then we have outputs reflected by a variable y, and then we have a function, which is the mathematical term of a mathematical model that receives inputs and produces outputs. So why do we use, or for what do we use decision models in health policy? Well, at the end, as I mentioned, a decision model is a mathematical model, and as all mathematical models are structured representations of a disease process, and in this case in mathematical biology, that are governed by a set of assumptions and parameters, which is very, very a key component, these two pieces, assumptions and parameters. So it's very important when you create a model to be very blunt and also transparent on what is the best of your knowledge towards that disease that you want to model. So we use them in health policy to simulate hypothetical cohorts or populations. So it's not that I'm going to simulate Fernando over time or Dr. Kunz over time. No, we're going to simulate some people or an aggregation of a population that is similar to the ones that we observe, and then try to model them over time or simulate what would happen to that population over time. And why is this useful? Because then we can evaluate different partially or yet to be observed policy strategies under different assumptions. Sometimes these strategies might not be feasible or ethical to implement in the population. Sometimes it wouldn't be feasible to conduct a clinical trial because it would be costly or mostly because of cost reasons. But with a mathematical model, we can represent the dynamics of such population or a cohort or a subpopulation, and then try to project different counterfactuals. So what goes into a decision model? There goes a lot of parameters and assumptions and information about, in this case, the disease. First of all, the probability of the disease. It could be prevalence or the probability of acquiring the disease, risk of future events, test characteristics, efficacy of treatment, risks of treatment, health-related quality of life, if morbidity is of interest to you and not just extending life expectancy, but also how does that relate to the quality of life of the patients, costs, adherence to treatment or adherence to screening recommendations or diagnostic strategies once the screening turns to be positive, adherence to all the cascade of following diagnosis and surveillance and treatment. And all that, it gets combined into two main outcomes, health and economic outcomes for each of all these strategies that are being considered in the decision model. And once we have these two outcomes for all the strategies, we eventually use those as inputs to make policy recommendations or to evaluate the policy implications of implementing such strategies. So what are the advantages of modeling? Well, it clarifies decision making, because once you create a decision model, in this case a mathematical model, you have to be very clear on how do you think the model behaves, or the disease behaves. What are the dynamics of such disease? So it's very important you have to make explicit what are the assumptions and all the components that go into this dynamic of the disease. Provides a comprehensive logical framework. Allows best available data to be applied for multiple sources. So it's also, a decision model is also considered an evidence synthesis mechanism. allows explicit and systematic characterization and treatment of uncertainty, because decision models is specifically useful to make decisions in the presence of uncertainty. And if you think about it, it's very difficult to make, it would be a very complicated challenge to think of a decision that someone would need to make in the absence of uncertainty. There's always the risk of making the right or wrong decision. So the idea with decision models is to quantify the probability, for example, of making the wrong decision and the consequences associated of making such a wrong decision. We also extrapolate short-term observations into long-term outcomes. So sometimes from clinical trials, and I'll mention this in a bit, we get information on short-term outcomes, and then from that information, how can we extrapolate to observe the effects on the long term? And this is very important. Encourages what if analysis. What if some patients would progress at a faster rate, would be at a higher risk? What if they are not as adherent? What would happen to them? What would be the outcomes that we will observe on such scenarios? So this is an example based on what we've discussed in the past couple days. So let's say a couple authors have already presented or talked about 2 clinical trials of H. pylori treatment. So in the clinical trial, there are patients that receive treatment, some patients don't receive treatment, and there are like some short-term outcomes like their H. pylori status after the SRF treatment, maybe mid-term outcomes like atrophic gastritis, intestinal metaplasia, or intestinal dysplasia. But ideally, we would like to know what would happen in terms of their gastric cancer in 10, 15, 20, 30, 40 years. Sometimes one of the longest trials were like 15 years. What will happen in 20, 25, 30 years? What's going to happen with antibiotic resistance on that population? What was going to happen with H. pylori prevalence over time? Life expectancy, quality adjusted life years. So for this is where we use the information from a clinical trial, short-term outcomes, and then we use all the best available information that we have in hand to then make projections on these outcomes of interest that will eventually help decision making, and that's for what we use a decision model. So I'll give an example of a decision model, of the outputs of decision model that is now used or was used to make decisions, and this was an output of SimCirc, which is a simulation model of colorectal cancer housed at Harvard and Minnesota. So this is a graph that was published at JAMA that, as part of the USPSTF analysis in 2016. And just to quickly explain to you what this graph means is comparing different screening modalities where we have different starting ages and begin screening, age to end screening, how frequent the screening should happen, every 5, 10, or 15 years. So here we're plotting, I believe, 20 different screening strategies that there's no evidence on clinical trials on these strategies, but it's just population being simulated under these different strategies, and we observe the number of life years gained per 1,040-year-olds that get screened, and what are the number of colonoscopies to achieve such benefits. As you can see, we then can compare across screenings, and the more you screen, probably the more benefit you will obtain, but also the more resources you'll use. And then we can determine which strategies could be dominated because, for example, this square, empty green square, might not provide as much benefit as, for example, the circle one, which it would be starting screening at age 50, every 10 years, and end at 80. So we'll see you're getting more resources that you'll need to do to perform on that population, but you actually obtain even less benefits. So now going back, try to land these concepts in gastric cancer. So there are different types of models in cancer. The most common ones are considered as chronic diseases. And for those, we use typically a state transition models. And for those of you that have done some economic evaluation, maybe you know them as Markov models. And there are different types of cancers that can fall into this category for which you could use this type of models. One would be colorectal cancer, breast cancer, or prostate cancer. But we have other type of cancers, as is been mentioned here before, that they have an infectious component. An infectious component means that it's not only a natural history of the evolution within an individual, but there's an infectious pathogen that accelerates or induces or causes such inflammation, for example. And a couple of examples of types of cancer that are caused by these infectious agents are cervical or anal cancer caused by HPV. So this is like, once you start modeling this type of cancer, you have to also consider transmission. Well, what happens with gastric cancer is one of the few, at least the only one that I know that has an extra component. And that extra component is antibiotic resistance. Why? Because, for example, if we're talking about HPV, we know that with vaccination, we can prevent the infectiousness or the infection of HPV. But with antibiotic resistance, we know that it's not guaranteed that with a course of treatment, the individual is going to get cured and H. pylori is going to be removed from the body. And not only that, by treating, we also induce antibiotic resistance into the body. So those dynamics need to be considered. And the only example and the only cancer that has these properties and the only disease to my knowledge that has 3 different components is gastric cancer. So we have a chronic component, an infectiousness, and also an antibiotic resistance component. And this is why I guess my lecture was called like Modeling Gastric Cancer in the 21st Century, because I'll propose what I've done in the past few years, constructing a mathematical model that will include those 3 components. So I won't talk too much about what gastric cancer is. Probably we'll talk this ad nauseum in the past couple of days. But I want to mention that it most heavily burdens low and middle income countries, having the prevalence around 70%. And we know it's the strongest non-biological risk factor of gastric cancer. But how does it look? What's the burden of the disease of both H. pylori prevalence and gastric cancer in Mexico? So first of all, in Mexico, before the introduction of clarithromycin into the market, so before it was approved by FDA and used in Mexico, we had a prevalence of 66% of the population was infected with H. pylori at the end of the 1980s. We had a huge variation across states, going from around 48% in Colima and all the way to more than 80% in Baja California Sur. Now, gastric cancer, compared to other incidence rates that have been exposed in this summit, are not like as high as, for example, Chile in Latin America or Guatemala or like Korea or Japan. But there's some stratifications that for some, but still lethal in Mexico. So it's the 3rd highest cause of cancer death in adults in Mexico. So it's still, and again, once it gets detected, it gets detected at a late stage, and as other colleagues have shown, is obviously of poor survival. So I don't know if you've seen a graph like this, but when I looked at this and was interested to try to model this problem, I saw this graph by Javier Torres and colleagues published in 1998 using that data of the prevalence that they collected in 1988 before clarithromycin was used. So it's a clear pattern by age. So we see how infection increases by age, reaching more than 80% in adults 25 years old and older. Now, we know that H. pylori treatment H. pylori can be treated with antibiotics, and however, we know that antibiotics can induce antibiotic resistance, and we also know that antibiotics can reduce the risk of gastric cancer. And clarithromycin is the standard antibiotic to treat H. pylori. However, we know that there's a certain prevalence, a significant prevalence in the region towards on clarithromycin from H. pylori. Now, there's been some suggestions even here with some conversations with colleagues saying, like, so why don't do mass eradication, mass treatment with antibiotic resistance? If we go through a traditional test and treat strategy, which is the common in clinical decision analysis, when you face this problem, if there's low prevalence, don't treat. If you have a huge prevalence, treat everyone. And there's a room, like a threshold in there, in which perhaps it's worth go and collect the data whether someone is infected or not. But if it's so high, why should we bother about testing? Well, just like treat everyone. Well, the problem is that if you treat everyone, we have the problem of antibiotic resistance. And I won't present the results here, but some components that or intermediate results of the model showing that if you do that, the pressure that you'll cause on resistance will go off the roof. So that's why it's not like a traditional test and treat component on clinical decision analysis, because of that resistance-induced problem. So the motivation was, what's the impact of treating H. pylori on health and cost outcomes? Would it be best to screen and treat for H. pylori instead? And to answer these questions, to really be meaningful, we need to consider what's the gastric cancer disease states, because that's what the final outcome that we're interested in measure. So the objectives of the project or of the talk that I'll present today, or I'm presenting, is the first one is try to characterize the force of infection of H. pylori in Mexico. The second is to develop an H-structure mathematical model of the transmission of H. pylori, accounting for antibiotic resistance, and then use this model, tag on a gastric disease model to it, and then evaluate the cost effectiveness of a population screening and treatment of H. pylori in the presence of antibiotic resistance in reducing gastric cancer mortality. So force of infection is a key quantity governing the transmission of infection with a given population. It reflects both the degree of contact between susceptibles and infected individuals and the transmissibility of the pathogen per contact. So what we did, we proposed a catalytic model, which is a type of survival analysis or time to event, but applied to infectious agents. So we proposed a mathematical model of how we think individuals get infected as they age. So based on this proposed model, we derived the force of infection, and then we used data and estimated the parameters of this model, and we did it at a national and at a state level. So we were able to derive the force of infection at both a national and for each of the states. So what we obtain out of this model, we are able to obtain what is the maximum number of population that will eventually get infected, and we obtain an 8.6%. And for those that get infected, what is the rate at which they're going to get infected, which was 9.3 per year of age. So how does the force of infection look like? Well, as we hypothesized, it was like highest at birth, and it decreases as individuals age. We were able to estimate the parameters and also the force of infection for each of the states, and this is the results of the force of infection for each of the states, accounting for also the amount of uncertainty in the data that we use to estimate it. So once we have the force of infection, we can then inform a mathematical model. So I'll present a mathematical model. I'll walk you guys through how I constructed a mathematical model of antibiotic resistance. So the simplest mathematical model of infectious diseases is the one that I present, which is a susceptible infected. It's a simple one, but very powerful. For example, it's the same model used to model HIV. And also the same one to model H. pylori in the absence of treatment, because we know that once individuals get infected, they remain infected, and that's it. But if we incorporate treatment, we can now get out of the infectious states and then go back again to the susceptible. A susceptible that is being treated, and then go back to the susceptible as not treated, but they are still at risk of reinfection. But if we want to incorporate antibiotic resistance, we need to expand this model to account for resistant strains of H. pylori infection. So this is what we did. And then we expanded it by age groups. As any model, it's good practice to conduct validation. Why? Because I can construct using the data and then show you, look how my model is, how good my model is to represent the data that I use to inform it. But what is really valuable to do is an external validation. What would happen to the model if I implement an intervention? Would it be able to replicate something that I observe on another data, on another population that was not used to inform the model? So one example of external validation is we took, for one of the states, which was Morelos, another seroprevalence study was conducted 10 years later. So what we did is we took the model of Morelos, because we also constructed state-specific mathematical models. And what we did is, like, let's simulate that population over 10 years and see how that projected prevalence looks 10 years later. So once I saw this graphic, once I saw this graph, at the time I felt really happy with myself, because okay, at least looks like there's a chance for me to graduate and get my PhD. So we were able to hit spot on the observed prevalence 10 years later in the state of Morelos. We also wanted to see how the model is predicting antibiotic resistance over time based on 3 studies conducted in Mexico City. So the data with starts with the points, star points, the ones that are observed from the 3 studies, and then our model is under predicting. But what I didn't mention is one of the parameters that is key in this model is the probability of mutation. And as I mentioned, I was only able to find a study with 8 individuals for which 3 developed resistance. So that's why the level of uncertainty, or the predicted uncertainty, and the bounds are so wide. Now, what I did is I incorporated Correa's model, the natural history model, on top of this mathematical model. So at the end, the final mathematical model consists a little bit over 2,100 differential equations. And that's the model that I'll use to make projections. As any model, I also have parameters that I don't have data on. So when we don't have data on parameters, we try to calibrate and that's it, derive the parameters of such model that will be able to replicate some aggregated level data. So that's what we did using a Bayesian approach. Then we evaluated different screening and susceptibility test strategies. So the idea was for screen and treat algorithm, the idea is like we just go and test, and those that test positive, we treat. The second type of algorithm is incorporating susceptibility test. What if you have a susceptibility test such that will tell you to which antibiotic H. pylori resistant to or susceptible, and then treat accordingly. I won't go into the test characteristics too much, but it's around sensitivity is 0.96 and specificity of 0.93 using a urea breath test, and similar to do a susceptibility test. So the interventions were, let's just simulate what is going to happen to the population if we don't do anything. So it's like the policy is, because in these cases a decision must be made, even if screening is not being implemented, it's a decision that is being actively made because things are going to happen to the population. So we say, let's do a no screen and treat strategy. Let's do a set of screen and treat in which we're going to screen and treat certain subgroups of the population and all the population. And then on those same subgroups of the population by age, we're going to incorporate a susceptibility test. And I won't go into the timeline, but this is typically what we do with the model. Like we stabilize it, and then at some point we say we're going to implement the policy, we're going to stop the policy, and then quantify what are the long-term benefits of that policy over time. So methodological assumptions, we tested whether such policies were cost-effective for Mexico. And in Mexico, the current guidelines is they're following the WHO guidelines, saying if a strategy provides one quality-adjusted life year below 1 GDP per capita is considered very cost-effective. If it's below 3 GDP per capita, is considered cost-effective. So Mexico GDP per capita was 132,000 Mexican pesos in 2013, which is roughly right now like a 6,500 US dollars. So the results, we evaluated all the 7 strategies, and we found that all but 2 were dominated. And those that were not dominated were the ones that would include susceptibility tests with screening. And for those 2 to 6 years old, but actually the most cost-effective strategy was to do, let's do a massive screening strategy, but also doing a susceptibility test, and then just treat accordingly the ones with the ideal antibiotic. So just to finalize, H. pylori screening and treating strategies could be cost-effective in Mexico, using at least the GDP, the threshold that is currently used in Mexico. However, with the high levels of resistance, screening for H. pylori has to be done, or ideally should be done with susceptibility tests. And the implications is that it will decrease the number of individuals that will eventually develop gastric cancer, and more importantly, that will die from gastric cancer. And given the substantial public impact, then we looks like at least doing more research on towards that line on investigating what are these consequences of screening and treating with susceptibility tests in Mexico. And we think it's a high valuable strategy, so should be a high priority to consider. Thank you.